Welcome everyone, and thank you for coming to our Research Tuesdays event today, Shaping AI Ethics in Health. I'd like to start by acknowledging the Kaurna people, the original custodians of the Adelaide Plains and the land on which the University of Adelaide's campuses at North Terrace, Waite and Roseworthy are built. My name is Alice Miller, and I am an environmental engineering researcher here at the University of Adelaide. Our event this evening focuses on the latest medical revolution, artificial intelligence. AI can improve healthcare with advancements such as accurate diagnosis, precision medicine, and accelerated vaccine development. But as algorithms increasingly shape human care, we have to ask, who's guarding the line between innovation and ethics? Fortunately, University of Adelaide researchers are working to define and implement ethical AI in the health field. Tonight we'll hear from one of these researchers, Dr. Melissa McCradden. Melissa is an expert in the development of ethical frameworks derived from clinical and technical knowledge grounded in policy, law, and moral theory. Amongst other prestigious titles, she's the Artificial Intelligence Director and Deputy Research Director with the Women's and Children's Health Network, and a Deputy Director in the Hospital Research Foundation. Please join me in welcoming Dr. Melissa McCradden to the stage.
Hello, hello. Can everybody hear me okay? Okay, great. Thank you. So I'm really excited to be here today talking to you about my research, some of which bridges my time in Toronto, Canada, and now here in Adelaide. So I've been here for about a year. I'm still learning, but it's really exciting to be here in the Australian context. By way of disclosures, I have some grant funding, and I've also served as an ethics consultant for these companies here, none of which influence what I'm saying to you today. So I would also like to acknowledge that we're meeting here on Kaurna land today. Always was, always will be Kaurna land. And I wish to pay my respects to their elders, past, present, and emerging. And I extend my respect to any First Nations people here today. I would also like to particularly express my gratitude to my partners at the Women's and Children's Health Network Aboriginal Health Unit, who have been working in partnership with me ever since I came here last year. So I have 3 key messages for you today, and I'm going to tell them to you right at the beginning, so hopefully we remember them. The gap in AI translation right now is about good evidence. It's about bridging the gap. That's where our work lies. The translational trial, which is a new method, which I'll talk to you about today, is one of the most important steps in this translation journey, and I'll talk about what that means. And then finally, our decisions matter most. We can have great algorithms, but until we couple them with good decisions, they won't help us improve outcomes. So here's your primer on machine learning. I thought it might be helpful to go into a little bit of detail about this. So you've probably seen something like this before. We've got artificial intelligence, this kind of big field that looks at computer science, that looks at philosophy, many other fields as well. And one of the ways that we achieve this function of artificial intelligence is through the use of machine learning. That's a particular field of computer science. A subfield of that is deep learning. This is where we have really complicated data, multimodal data, so images, text, tabular data. But what I want you to remember, if you can remember back to, this one always brings up for me my high school classes in algebra where we had that, y equals mx plus b, that little parabola shape. There's a function there. And the function tells you what's the relationship between the set of data and this thing that you want to predict. What is that math that represents the relationship between the data and the outputs? So we can look at this in many common examples. If you look at the Netflix algorithm, what they're doing, their data, there's shows that are watched by the same users. There's some mathematical relationship that tells Netflix that for you, it's going to predict this show because it looks similar to the shows that other people have also watched. If you look at Google Maps, we've got traffic data. So we know what the roads tend to look like. We've got information from satellites. It's going to give you a projection of how long it's going to take you to get to a particular location. It's the same principle that underpins work in medicine. So for example, in imaging, each of those little pixels on the screen, that's a source of data. And so by identifying relationships among that data, we can develop AI tools that tell us, is a tumor present or not? Similarly, if you're in somewhere like the ICU, where you have things like heart rate monitor, oxygen saturation, other kinds of signals about things that are going on in your body, we can look at the relationship within that data and predict whether someone might be heading for a cardiac incident. But one of the things that I want you to think about here, what questions does the data not help you answer here? So if you look at some of these things, let's look at Netflix, for example. Just because Netflix has predicted that you will like a show, that doesn't mean you're going to like the show. I've gotten plenty of terrible recommendations, sometimes because my kids are playing with my Netflix profile, but other times simply because I just don't like the show that it's predicted for me. Similarly with Google Maps. Everybody in Toronto knows that Google Maps continues to think that there are these two key intersections where you can turn left. You cannot. And so the prediction is always wrong. Similarly with medicine, there's cases that fit the norm and there's cases that don't. And so thinking about what computers can help us do really well also helps us think about where we need that human expertise. So this is actually quite similar even with large language models. So if you've used ChatGPT or Claude or Gemini, there's a billion of them at this point, it's a similar principle. In this case, your function, or the mathy math, is just about the relationships between words, which words tend to go together. If you pull out your phone right now and you're about to text somebody, you type a couple words, you're going to get a prediction for what word is going to come next. It's based on past patterns, it's based on the algorithm, and so ChatGPT is sort of an amped up version of that, but it's been trained on all of the internet. So because of that, you can generate responses to all kinds of queries like this, and they look really good. The really important part to remember about this, and the part that is different to a lot of the other things we do in medicine, is that what they're trained to do, that output that they're trained to predict, it's not about being right or wrong. It's about looking good. It's about good text. Does it sound right? It's not actually trying to be accurate. So these are a little bit different of a system when we compare with most of the applications that are in medicine right now. And I'll talk a little bit about both of those. So here's how this started. So back in 2016, I think 2017, one of these big godfathers of AI makes this sweeping declaration that we should stop training radiologists now because they're all going to be extinct in 2020. Similar claims were made actually of self-driving cars. So there's quite a funny meme actually that shows, year 2025, radiologists still driving to work, still driving their own cars, not self-driving cars. So sometimes the predictions that our big tech voices make don't always line up with reality. One of the reasons for that is that very often we're missing this connection between what an algorithm can do and what the real world context is. So we do not have robot doctors, probably won't actually have robot doctors, and there's a good reason for that. Now, on top of this, although we do have some good examples, we also have bad examples. Some of these come down to not doing a good enough job making the right algorithm. Some of them come down to making bad human decisions. So one of the examples that we're talking about here in the Denied by AI series, this was what happened in North America. There was an algorithm that was supposed to predict whether or not a patient was ready to be sent home after a hospital stay. The algorithm was implemented, and doctors were observing that the algorithm was making these predictions to say this patient can go home. But they were saying, I don't think this patient's actually ready. The hospital administrator turned to the doctor and says, well, algorithm says go home, send them home. And unfortunately, this resulted in a lot of harm for a lot of people. So it's now the topic of a class action suit. So this highlights the stakes. If we get this wrong, there's this saying that people can screw up, but to really screw up, you need a computer. because they scale. One of the other examples is this EPIC sepsis prediction model. So this is a pretty well-known case now in my field where the model was implemented to detect sepsis. It turned out that even though the developer of the model claimed that it was accurate over 90% of the time, when they actually tested it in different hospitals, it could be 90% accurate, but in other places it was down to 17% accuracy. And I'll talk a little bit about why that sort of thing happens. So on top of this, we've got now our large language models, our big generative AI models. I don't know how many people saw some of this kind of hilarity around these AI overviews. So this was one where someone had asked, what's the difference between a sauce and a dressing? And so Google responded, well, sauces add flavor and texture to dishes, while dressings are used to protect wounds. Even had really helpful pictures for you if you want to see the difference. There's been other stuff like putting glue on pizza to have it stick to the pizza. You should eat one small rock a day. There's all sorts of these kind of silliness. And again, it's because they're trained on text. So in Canada, we have this very famous kind of satirical publication. And so it makes silly stories out of the news. But that's treated the same way by these models as something coming from University of Adelaide researchers or from the WHO. It's all just text. Similarly, we're seeing this in the legal space. So you may have heard the story of the lawyer who relied on ChatGPT to generate a case briefing. Turns out that many of the cases that were cited in this briefing note were fabricated. And the poor lawyer says, no, I asked ChatGPT if they were real, and ChatGPT said they are real, and here's the citation. But again, they weren't actually real citations. They were hallucinations. And so unsurprisingly, people are starting to wonder what's going on here. Why is this happening, and how are we supposed to trust this sort of a system in the healthcare environment? And I think that that's really a very reasonable question, one that we have to navigate in order for us to safely and ethically use AI in a healthcare context. So what's going on? Well, there are many good examples. There are examples of how AI tools are helping us improve care, usually coming in the form of randomized clinical trials, so strong trial methodology. So for example, asthma care pathways have been shown to be improved with a particular AI model. Monitoring in the ICU was something that my previous hospital sick kids did really well at. We can trigger mobilization for the right resources for people. So helping them link up with social services, with other forms of support that will help their overall health. And then finally, helping with documentation. If anybody's been to the doctor lately, you've probably encountered one of these models where your doctor might ask you, is it okay if I transcribe this note? So this is somewhere else where people are really looking to these tools to help in healthcare settings. But how do you know if this tool is going to work at your setting? Given all of the examples that I've just made, we kind of know that there's sort of this promise of AI that is not necessarily the same as a tool being able to deliver value in your local setting. And it turns out that whether or not an AI tool works is actually pretty complicated. So in healthcare, unlike Netflix, we can't just say, well, we gave the recommendation, we did a good job. We have to connect that to something real that happened to the patient or something real that happened within our healthcare setting. And there's two ways that this can go wrong. One of them is alert fatigue. So you could have a perfectly accurate algorithm that alerted you to every single one of the patients who was going to have some kind of trouble. But you're also going to be alerted to lots of patients who aren't in that situation. You're going to have a lot of false positives. And most of all, you'll have a very, very annoyed clinician who has to constantly dismiss alerts that aren't clinically relevant. On the other hand, and what happened with the sepsis prediction algorithm, this was a case where we had a model that was being implemented that was only alerting clinicians to the potential for a patient to have sepsis after the doctor had initiated treatment for sepsis. So that's not going to be particularly helpful either. So it's actually a little bit more complicated trying to figure out how do we get the right alert for the right patients at the right time to actually help their outcomes. So what is the right kind of evidence? Well, if we look at where a lot of the evidence sits, it's in this sort of technical performance bucket. So this is where we've got a good algorithm and it performs well. In healthcare, it's sort of like doing really well at a simulation or at a practice run. You've got sort of cleaner conditions. You may have controlled for certain things. It's a lot more straightforward to have good algorithm performance in this context. But the real world looks like this. It is messy. We have people misentering things into the health record. You've got patients partway through their journey. You have a lack of clarity as to their history that's in the medical chart. You might have multiple competing forms of documentation. Some of them might be paper, some of them might be electronic, some of them might be patient reported. And so this is actually the context that we need to look at really clearly to help us figure out if we're doing the right thing by integrating an AI tool and how we do that in the right way. So we need a combination of technical performance and clinical evaluation. Now the latter is where we've had a lot less focus over the past 10 years. So that's where my colleagues and I at Sick Kids really look to figure out how can we promote the collection of this sort of evidence. And we ended up coming up with this 3-stage pathway that actually has a 4th stage of monitoring. In the first stage, this would be facilitating many of our clinicians who are at the bedside to identify problems that we can potentially develop an AI tool to address. So this way, these ideas are coming from frontline staff rather than from outside, and we're trying to address patient needs. Once we have a model that is working reasonably well, and we think could be something that we could use to improve care, what we do is we move it into what's called a silent evaluation phase. So much like your phones might be on silent mode right now, I know mine is, you're still getting messages coming through, but you're not seeing them right away. You look at them later. So they don't influence how I'm giving this talk right now. We can do a similar thing with algorithms. So before we know that they're actually going to help us, we can run them silently so that we compare it to what actually happened to make sure we're not changing care before we have that evidence. Once we pass that step, that's where we're collecting clinical evidence. That's where we want to see what is the impact of using this tool on some patient-relevant outcome. So there's emerging consensus around this framework, including my colleague Anton van de Weet and colleagues over in Queensland Health, who have developed what's called the Salient framework. And the WHO guidelines on clinical evaluation are also coming to this 4-stage process. And what it's really about is about looking at how we generate evidence already in medical contexts and how we map AI tools onto that. So, for example, if we're looking at the pharmaceutical pathway, at that initial stage, you want proof of concept. That's the same thing with AI tools. When we're developing algorithms, we initially need some proof of concept. Can math be used to help address this outcome? At the 2nd stage, we're running that silent evaluation. So that tells us how the model is performing in our hospital with our particular patient cohort in our setting. It's where we can also check for the economic implications, the environmental impact of running the model, and engage our consumers in a better way compared with the 1st stage. Once we do that, then we test the effect on the outcomes. We're not always going to run a randomized controlled trial, but we always need to do some form of clinical evaluation. So whether that is checking an observational study, it involves some form of measuring the real impact of these models on the care of patients. So I'm going to focus a bit on this orange one here, which is the descriptive evidence. So this is the silent trial phase. So first of all, we have to talk about why we actually need this. Again, it's about outcomes. ultimately, we're not implementing AI for the sake of doing AI and looking very cool. It is to improve healthcare. It's to improve it for the system or to improve it for patients. Again, we have lots of work on the math of AI in healthcare, but a lot less work demonstrating that impact. And this has been proven in the literature as well. This was a recent systematic review that looked at 18 clinical trial studies that had a patient-reported outcome. Only 4 had a low risk of bias, so a lot of them had a very high risk of bias. And 12 out of 18 did report benefits to patients, so that's really good. However, the inclusion criteria were that the trials had to measure a patient-reported outcome. So if you zoom out, it's actually 86 trials that are going on right now, and so of those, only 18 had a patient-reported outcome. So we need to do better at collecting information on what the impact is to our patients. So it's good that more clinical trials are happening, but when do we do a clinical trial? Is it always appropriate? And how do we make that decision? So going back to those stages of translation, I've talked to you a little bit about that red box there, which is designing an AI trial or designing an AI tool. The orange box, it's called analytic validation in the WHO guidelines. We've called it a silent trial in our context. And then moving on to the next stages. So focusing in on this stage, what's happening here? What are we actually doing here? Well, again, if you look at how this fits in, we've got guidance around some of these things related to making a good model, doing clinical trials, doing monitoring. And so my project, which is Canary on translational trials in healthcare, fits in this middle spot. So helping us bridge that bench research and moving into clinical trials. So again, the silent evaluation stage, this is when we have what could be considered a good model. So it's been well validated. We run it live without affecting patient care. An AI team checks those predictions and then checks what actually happened to the patient. So for example, if the AI tool is suggesting that or predicts that there is a tumor present, someone has to check, was that correct or not? Is there actually a tumor present or not? If an AI tool predicts that this patient could have sepsis, someone has to check, do they actually develop sepsis or not? And there's another aspect here which is called socio-technical evaluation. So it's not just about how the AI model works, but it's about how the human who's using the tool interacts with that tool. If they know how to use it well, if it helps them in their decision making, if they understand how that model has kind of generated that prediction. There's certain things that we also need to understand about the humans who are making those decisions. Consumer engagement is incredibly valuable across the entire stage of, or across the entire life cycle of AI development, but particularly here, because this is where we can tell a consumer, here's how the AI model is going to work here at this hospital for patients like you. That can help us make good decisions about how and when we move forward with integration. Our consumers ultimately are the recipients of this technology. They're the ones we're hoping to help, and so their voice has to guide us in figuring out how and when to implement. And then finally, incorporating Aboriginal ways of knowing brings immense value to any of these projects. My colleagues who work in this space, their knowledge of the data, of the context that it's generated in, and of what is relevant to their communities is absolutely essential for making sure that we get this right, and there's no substitute for consulting them. So this project is actually looking at, well, how do we do this? So what you'll find is that there's some teams who are really good at the machine learning part of silent trials. There are some teams that are really good at the human-computer interaction part. Others are doing the economic evaluations. And so the idea with Project Canary is that actually, if we put all of this together and we give guidance around what's the whole package that you need here right from the get-go to get it right the first time you try, we can not only help people develop and integrate more AI tools, but doing that better. So preventing barriers and helping them get it right the first time. And this work has been led, this is my collaborator, Dr. Xiao Liu, who ran a lot of the international consensus guideline studies on clinical trials in AI. This work has also been helped by Lana Tikomarov, who is my PhD student at University of Adelaide. And so her work is looking at the literature, looking at what's out there, who's doing a really good job at some of these different pieces of translation, whose expertise can we draw from to help us come together and develop this guidance. So looking at the CANARY scope, we've got a really wide scope. It's not just about the model. It's about the clinicians. It's about our consumers. It's about our Aboriginal partners. It's about economics. It's about environmental impact. It's about healthcare sustainability. Our goal is to learn from people who are doing different approaches to any one of these aspects of translation and put it together in a package so that if you're a hospital in downtown Toronto, or if you're a hospital in Dubai, or if you're a hospital in Brazil, that you can take this package and you can translate an AI tool into that setting to a high quality standard. And so the result is really this whole package for an AI product. So again, that helps us with efficient translation, it helps us with better quality, and it helps us make sure that we center translation on something that is good for patients and good for the healthcare system. And so how we're doing this at Women's and Children's is actually looking at how can we map these different stages to the National Safety and Health Quality Service standards. That's what we're accountable for as institutions, for keeping patients safe, for providing high quality care, and for providing evidence-based care. So my job for the past year has been to look at what are we required to do under these standards, and how do we take all of the pieces of AI translation that we need to do, how do we map them under those standards? Once we do that, we also have to look at our own hospital's context. So for example, Women's and Children's has a values statement. We have our CREATE values. We also have our strategic vision. And we also have our Aboriginal health policy. Again, my colleagues in the Aboriginal Health Unit have made looking at AI models and looking at data-driven impacts as part of their mandate to make sure they understand and can advocate for the best health for their communities. So again, looking back to this translation life cycle, governance is the whole thing. It's the whole package. Governance has to help with doing good design and development, with doing translational trials really well, with doing clinical trials really well, and making sure we know what exactly we're monitoring when we get to the end of this pathway. So my last point here is that our decisions matter most. We can have these really great performing algorithms, but we need to couple that with good decisions in order to do right by our patients. So one of the things that I know in an ethics context is good decisions aren't always right or wrong. And I say that because a lot of my experience has been in the intensive care environment, where we have uncertainty about what the best decision is for a patient. We can have different views on that. So for example, in pediatrics, a parent might disagree with the recommendation of a healthcare provider. They're both looking at it from a best interest perspective, but those perspectives might not align. We also might have situations where we're uncertain because we don't have enough evidence, where we're not sure whether something will actually help a patient or not. We still have other situations where we might not have anything to help a patient, and their best option might be something like a clinical trial. So there's many situations where we don't necessarily have a clear right or wrong answer. And so how do we navigate that uncertainty when you add that on top of something like an AI tool? So my colleagues and I ran this study, which ran for a few years, where we looked at how do people make good decisions with healthcare machine learning tools. And to run this study, what we did was we started by speaking to colleagues in the sick kids intensive care environment. And we gave them a situation that mimicked a typical ICU handover. So if you're the physician who's coming in first thing in the morning, you've had a resident on overnight, and that resident presents the patients to you, tells you what's going on, here's what's coming up for the day. So in this case, we gave them a scenario where we had an 18-month-old infant, where the decision was, are we going to extubate this child today? When we look at something like extubation, it's a matter of risk management. If we do it too early, the child might not be ready for extubation and might struggle. We might need to re-intubate. If we do it too late, we've kept a child on a breathing tube for too long, and that can have harmful effects as well. So it's a decision that is carefully calibrated. We also told them that this particular kid had some medical complexity. So this child had some issues with their genetics where they had airway differences. And so that might make it more difficult for us to take that breathing tube out. And so we asked the clinicians, how would you manage this patient today, given these factors? And then we asked them, if you had a model that said it's 60% likely that this patient will have, that extubation will go well, how does that factor into your decision? And so the funny thing was, initially, this study started as a study on explainability. So explainability is this method where the AI developers can give a reason behind a particular prediction. So if you've ever been on Facebook and you have that thing that says, why am I seeing this ad? That's a type of explanation. Do you trust it? Is it always right? Not really sure, because what we know sometimes is that as much as AI models can be wrong sometimes, the explanations can also be wrong. So initially, we thought that it was just a matter of giving our doctors a good explanation, and that would help them navigate these things. And it turns out we were wrong. It was actually a lot more complicated than we thought. And what we ended up with was this rainbow wheel of considerations. So we found that to make a good decision, first of all, they grounded it on their patient's best interests. And so yes, the algorithm says 60%, that's great, that might be valid, but that's not all that a clinician is taking into account. 60% risk for a patient who may have some medical fragility is very different from a patient who doesn't have that. And so they looked at that risk assessment in the context of that individual patient. To make that decision, they had to draw from their medical knowledge system. So what do they know about the conditions that this patient has? What do they know formally from clinical trials, from literature, from practice guidelines? They also needed to know about the context. So they needed to know, for example, is this a family that wants to be at the bedside for that extubation? Do we have a team on hand who can intervene if something goes wrong? Those sorts of things might be subject to the time of day. So even if there's a good algorithm prediction and we're confident in it, if that team is not available at that time, that might change our decision. We also needed to know how that context is factored in for that specific patient. So patients surprise us all the time. Sometimes we think that a patient isn't going to do well, but they do. Sometimes it's the opposite. And it takes a really keen clinical eye to observe that individual patient to see how they are actually doing. So clinicians talk about it all the time where they have this knowledge system, but they then need to take into account the patient that's in front of them and individualize it. Now, when it comes to machine learning, clinicians wanted to know general facts about the model. So they wanted to know, for example, does it have regulatory approval or not? They wanted to know generally how it performs, but the most important thing to them was how does it perform on my patients? That's great that it did really well at that hospital in that other state, but I want to know how it has done on my patients in this unit. And part of what they drew from was their own context. So they wanted to know what their experience had been with the model or what their colleagues' experience had been. And a lot of people said, ultimately, you can give me a number for how accurate this is or isn't, but my experience is going to trump that. I'm going to see if it's going to work for my patients or not. And then finally, they also wanted to look at the biases that are internal to medicine and their own practice. So for example, when we talk about things like genetic differences, the history of medicine has not always looked kindly on people with those conditions. So for example, at Sick Kids, we routinely revive patients with trisomy 18 or with Down syndrome. That wasn't the case 20 years ago. And so there were very pessimistic views on whether a patient would survive and what their quality of life might look like. And so many of our participants pointed out that, you know what, our knowledge on how this patient might do is actually quite fragile because we thought it looked one way, but we were studying it the wrong way. Turns out it's actually much better than we thought. And so thinking about how those types of biases had entered into their medical knowledge, had influenced the practice by some of their mentors, those were things that they had to think about in the context of this prediction. So all in all, these clinicians who participated, they wanted to reflect across all of these different considerations and put it together to say what is the best decision for this patient. And this kind of brought me to this sort of second part of my career where I was like, okay, well, if explainability is not that important, what does that mean for medical legal liability? And so I worked with, this is my colleague Ian Stedman, who is a health law scholar up in Canada. And so we looked at what are the standards for medical decision-making under the law. And under the law, it's not necessarily about were you right or wrong, it's about whether your decision was reasonable. And when we look at what is reasonable, it's usually looking at, did you take into account the totality of evidence? Would your colleagues have done the same thing under the same circumstances? So that makes sense when we think about the fact that not all clinicians are equally situated. Somewhere like Sick Kids, which is a massive research and teaching hospital, is not going to look the same as a hospital that might be in the northern sector in a more rural region. And so the justifiability of a clinician's decision is going to have to take into account that context. So similarly, with AI tools, we need to take into account that context. Now, the history of how people have kind of looked at this, if you look at, there was the dominant paradigm, which for a long time, and still to some extent, says that, well, we just need to understand how the AI generated a prediction, and we need to make it explainable. And then it's all fine. We can have good decisions. There's a second step here where they said, okay, well, hang on. You can have a good prediction, you can have a good explanation, but patient values also matter. So we put them together. My colleague and I are pushing this a little bit further. We're saying, well, yes, all of those things are good, but you have to take into account the evidence behind this specific tool and what you know about it in your local setting. So maybe it's got really strong evidence from a clinical trial down the road, but have you tested it at your institution? Have you seen how it works for your patients? And so what we hope this results in is a better way of reaching the shared decision-making model that is the benchmark of modern medical care. And to look at how this might work, we considered a couple of examples. So case one, this is from one of my colleagues' hospitals down the street. And this was actually a real case that we had discussed together to figure out how to deal with this. So under this model, again, it provides a discharge readiness score. So it's supposed to help clinicians decide, is this patient medically ready for discharge or not? Now, the hospital that we're talking about deals with a lot of people who have socially complex needs, people who might be underhoused, people who might be in need of additional resources. All of these things speak to their potential fragility if we discharge them early. And so if we look at a machine learning prediction that might give something like a 60% readiness score. If you are a patient who's got good resources, you've got a family to go home to, you've got a secure job, and you're reasonably well supported within your community, the risk of you going home too early is a lot less than for someone who has that level of social complexity. And so we felt it's quite reasonable for a clinician to make two different decisions given the same AI prediction. So for one patient, we might say, okay, you're ready to go home, we'll let you go home. But for the other patient, we say, let's hang on, let's see how we can better support you. Are there other things that we can do to optimize your discharge a bit further? The second case is looking at ChatGPT as a diagnostic aid, which is something that people do. I'm not saying this is good or bad. You can ask me after for my personal opinion on this. But it is a thing that happens. So people might enter things into ChatGPT to try and understand. Maybe there's something that they're missing. Maybe there's some recommendation or something that this tool can come up with that might help them figure out what's going on with this patient. So if we look at this reasonableness standard under the law, we might say, okay, clinicians can and do consult the internet for any number of things. You look at things like UpToDate, might look at other sources as well. There's a lot of patient blogs from their own life experiences that can also help us better understand what might be going on. But ultimately, let's say we use this and it gives a set of possible diagnoses. Whether or not it's reasonable to pursue those diagnoses relies on the clinician also looking at what is that patient actually experiencing. Do we have other tests that we can do to figure out if that makes sense or not? If you integrate that patient's history, does this make sense or not? And what are the risks of not following up with one of those diagnoses? So in some cases, if a patient goes home without a diagnosis, something might go away on its own. On the other hand, the risks of missing other sorts of diagnoses might be so substantial that a clinician might want to follow up. The point is that it's all contextualized in light of the person that's in front of them and in light of the other information that they know. It's never AI versus clinicians, it's the whole context together. So key messages that I hope I've conveyed today are that we need to be generating more evidence about the actual impact to the health system and to patient care in order to bridge this translation gap. The importance of that translational trial for collecting local information about your patient population in your patient setting is a very important source of evidence and something that we can actually govern to ensure patient safety. And then finally, our decisions matter more than the output of any AI tool. So thank you so much for coming today. We've got lots of time for questions, and I will be here after as well. Thank you.
Thank you so much, Melissa. We'll now open it up to questions from the audience, but I'll begin with a pre-submitted question. So the question is, are there policies in place to inform patients that AI will be used as part of their care?
Yeah, it's a really good question, and it's one that I'm asked a lot, and I think it's actually changed in recent years. So there aren't specific policies in place at this point. Notwithstanding, patients always want to know about AI tools. I think I have yet to encounter people who have said, no, you know what, I don't really care. So I think there is a consensus that patients want to at least be informed and ideally have the choice about whether or not an AI tool is used in their care. The only exception to that would be if an AI tool became the standard of care. Then we might have less leeway to opt out. How does something become the standard of care? You have to have a very large body of evidence that shows that this way of doing things is definitively better than what we were doing before. And we just aren't there yet with a lot of AI tools.
Is there any questions from the audience up the front here? Can we start? Or sorry, shut.
Thank you for your talk. You mentioned that the mathematics behind AI computation is extremely complex. I'm interested to know, in relation to the programmers that increasingly are moving into the AI programming field, whether they now require a much more advanced mathematical background themselves, or whether there is another layer involved where you have mathematicians developing tools and strategies that they simply build into a much more usable framework for less mathematically inclined programmers to use?
Yeah, that's a really good point. So it's sort of interesting how machine learning researchers have developed almost in parallel to like biostatistics or statistics proper. So much so that it's almost like they're speaking different languages sometimes. So if you've ever kind of heard that thing about correlation is not causation, in machine learning, there's a lot of emphasis on correlation without always the rigor that comes with traditional statistics approaches. And so a lot of programmers, because of AI training courses and all these other kinds of things being so accessible, they're jumping into a lot of these areas. And so they're using these tools to develop these models, which, yes, just because you can predict something doesn't actually mean that you can in the real world. So there was this other really funny example from the North American context where they generate all of these different like correlations. So there's like the price of cheese with people's shoe purchases and like just random stuff like that. And that's sort of where a lot of AI is, where they're like, oh, we can predict a thing. This is really great. We can do something. But then when you look at actually the real world context, it's very different. Just as an example, we have kind of, as a field, moved away from things like mortality prediction. One of the reasons is that it's a really easy machine learning task to predict someone's probability of dying in hospital, because it's a really clear label. You're either passed away or you have not. So it's a really good machine learning task. But the reasons that people come into hospitals are so complex, and you can't always act on a lot of them. And so the model itself clinically is actually very often quite useless, because there's nothing you can do on the basis of a lot of that information. However, if you're predicting something like whether or not a patient might need an ICU bed, you can give that information to someone else to make sure the bed is ready, to make sure we've got the right number, to make sure we're staffed appropriately. So there's this shift in focus on actionability, and I think that's where a lot of the programmers are now starting to move. They're starting to move into a space where they're looking at how do I kind of make my math more real world appropriate.
Question, thank you. Up the back there.
Okay, yes, thank you. How would you apply these frameworks to all of the algorithms in the healthcare system that aren't AI? For example, the surgical waiting list, where you classify patients as 1, 2, and 3. That is probably ad hoc calculation, which is not applied with ethics. There are so many spreadsheets in healthcare. Just who gets treated next? How do you approach those in the same way as machine learning algorithms?
Yeah, absolutely. So we actually tried to develop this framework based on some of those other systems. So there's on clinical algorithms, it's hard when you try to kind of do a search for them, because sometimes that means something like a regression, where it's like we're predicting this outcome based on 3 features. Other times it might mean a particular decision pathway. And so what we do find is that in healthcare, usually when you're developing those sorts of things, there's quite a lot of methods that go into them, variably so. But generally, there's an approach that is grounded in the patient experience. And we don't necessarily see that for healthcare. So for AI. So one of the things that we did actually ask at the hospital after doing all of this, because we were considering some of that, and we also had a surgical wait list actually. And so it depends on what the task is. So for example, if you've got a surgical wait list where you're prioritizing patients under a situation of resource constraint, you're sort of just giving an ordering and you're slotting patients accordingly. That's very different from if you're making a prediction about that patient's outcome. And so we might treat one like an algorithm that kind of guides that prioritization, whereas the other, we would treat it like clinical decision support. But there's certainly all sorts of examples where the same rigor maybe hasn't gone into some of the algorithms that we use. And so I think it's a matter of looking at, are there aspects of what we're developing in this health AI space that might actually be quite suitable to other things that we do in healthcare, all with the goal of improving that quality and safety.
Do you have any other questions in the audience?
Thanks. You drew parallels a few times with drug development and phase 1, phase 2, phase 3 regulation. With drug development, when you finally make money is when the regulators says, yes, you can market it in this country. But no drug gets to that stage and patent on it. What's happening in this area in terms of commerce, patents? Can anyone make any money here? And how will it influence which direction the whole thing goes?
Yeah, great point. So the TGA regulates software as a medical device, which includes AI-based software. And so there are, my understanding is that the TGA has processed quite a few applications, and there are many that have gone through the pathway, probably not as many as the FDA in the United States. There are a number of companies that are looking to make money, and so part of that is they're trying to sell their solutions. And that might work, it might not. I think it's very startup culture, so you sort of either are kind of the primo candidate or you're likely collapsing. So there's a lot of that where there's people kind of working all over the space, and I think that makes it very hard for if you're in a situation where you're in a healthcare environment and you've got this company coming at you with this algorithm and this company coming at you with this algorithm. How do you figure out which one? That's actually one of the things that we're proposing. If you do a local trial, you can figure out if it's going to work for you. But so there are other companies who are going through the TGA to try and make some profit. There's also some really great examples of some folks here in Adelaide who, rather than developing a company to sort of make a lot of money, they're actually putting the money back into the healthcare system. So there's a couple of examples of those. But all of those are kind of predicated on the device in question being something that's regulated. And actually, a lot of stuff doesn't fall quite under that bucket. So particularly tools where the team isn't looking to make money off of it, isn't looking to sell it at a hospital across the street, is just developing it internally to improve care locally, then they wouldn't fall under the TGA bucket as regulation currently stands. And actually, one of the complicated cases is these language models. So some of the tools that are doing AI scribe functionality. These ones, there seems to be consensus in the research community that they should be regulated. They are not currently regulated. And so they're sort of in a like no man's land at this moment. They do perform medical device-like functions. And so I think the TGA is increasingly looking at that and trying to figure out what do we do and how do we address how kind of ubiquitous these tools have become. And it's a really hard problem. It's a really hard problem because they themselves they're not well resourced to reach into every single hospital, every single clinic across the country. And so I think then again, it's why it's even more incumbent on local institutions to develop guidance to support their clinicians in navigating these questions.
Thank you for your interesting talk. Your work is focused more or less in the present. I just wonder if you can look forward 20 years and give us a prediction of where AI will be then in the medical field.
Yeah, so what I would like to see, and what I think is probably most likely, is the use of some of these tools to do these little small functions that make a big improvement. So improving things like accessibility, making discharge instructions more easily read by patients, helping patients have a better experience with scheduling, helping us staff hospitals better. It's all of these administrative tasks where I think there's actually immense value. Like one of the examples that the consumers at Women's and Children's have continually brought to us is, you know what, yeah, lots of people are like, oh, AI can do this and that. You know what I want it to do? is if I live out in this rural area and I have 3 appointments at Women's and Children's, I want them on the same day. Like, that's all they want. And so we can do that. Similarly, for the nurses who have to do visits out in the community, they're like, I have all of these different addresses. I have to put them into Google Maps and figure out what the best route is. Why can't we just schedule people based on zones, based on timing, give an estimate time of arrival, just like you can see when your Uber driver is coming? Can they see when the nurse is arriving? So I think that what I would like to see, and where I think the most value is these small things that make a big difference for our patients and for our staff at the hospitals.
Time for one last question, and we'll throw to the online.
Great. Just a question from online. Is there any focus on using natural language as a data source, not just set data points? For example, extracting relevant data and observations from voice notes or AI scribe.
Yeah, definitely. So there's a couple of examples where natural language has served as a data source. And that is helpful because it kind of captures the way that we speak more than sort of written notes do. So it depends as to like what the application might be. If you had something where you wanted to have a conversation, then that tone of speaking might be the right training data for a tool like that. So for example, there's some work in social robotics where people want to have a conversation with a robot. And so that might be a good place where that goes. We also use natural language processing. Sometimes I like to say, not everything is a large language model. Natural language processing, also really good and really helpful. So for example, some of the tools that we've developed in the emergency department, they look at the triage notes and they might grab, symptoms that go together and turn that into a variable that an AI model can then make a prediction off of. And so that's good old natural language processing, and it can be very helpful for those sorts of tasks. So really it's about what is the right method for this particular task that we're trying to do.
Thank you. We'll wrap up question time now, but I'd like to end the night by thanking tonight's speaker, Dr. Melissa McCradden, and thank you to you, our audience tonight, for your viewing and wonderful questions and comments. Be sure to sign up to our mailing list to receive information about Research Tuesday's related news. And thank you again for joining us tonight for Research Tuesday, and have a great rest of your night.
Thank you.